I'd just like to invite Alison Coull to the stage. Alison is actually just completed her PhD looking at leg ulceration in young people who inject drugs, and is actually the first nursing doctorate in Scotland to be associated with tissue viability.
Thank you.
She'll hate me for that, by the way.
Yes. I'm going to talk about leg ulceration in young people who inject. It's a growing population, and one for whom there's very little evidence, which is why I did my PhD. And there rarely is mention in not just the evidence base, but in textbooks and any sort of guidelines. People who substance misuse are rarely mentioned, but it is a population that's getting bigger. So I'm going to draw attention to some small studies of relevance to that group and finish just with a slide about treatment. Of course, ulceration in young people is not that unusual. We think of the elderly leg ulcer patient, but actually 30 years ago when the Lothian Forth Valley study was conducted, 22% of their sample had ulceration before the age of 40. Mackenzie's paper published in 2003 described consecutive patients attending a leg ulcer clinic, and that 46% of them had developed ulceration before the age of 50. But they were a distinct group, tended to be male with a history of being overweight, with long bone fracture and DVT. However, in these papers about young people, there was really no mention of intravenous drug use, and I think people working in leg ulcer clinics now will recognise that they're seeing more and more people with a history of substance misuse and leg ulcers. And as I said, the evidence is poor, and the definition also can be quite poor, particularly in the addictions literature, which talks about problems with injecting causing ulceration, but misdefines soft tissue infection. So ulcers are lumped together with soft tissue infection. In the Shooting Up report, they're defined as open sores or wounds that are open, which obviously doesn't necessarily mean that they're infected. So one of the issues that occurs with managing younger people with leg ulceration occurs at the initial assessment. When I first started working with substance misusers, and they were all generally young people, under the age of 40 predominantly, when I was conducting Doppler tests, I found that their ABPIs were raised. They were well over 1. And I was a bit puzzled about that. And then I thought back, well, the students that I've been teaching Dopplers to also had raised ABPIs, and I had assumed it was because you didn't lie them flat in the classroom and they were sitting up when they had their Dopplers taken. But that led me on to doing a study, because I worked within a service where there was a protocol where if the ABPI was 1.3 or more, the patients had to be referred on to secondary care. And my group of patients are very reluctant to engage in going to hospital, attending appointments. They just didn't want to go, so care was withheld. They didn't get compression until they'd attended for Doppler and further assessment at hospital. So that was problematic and led me to do a couple of small studies with students that I had. And in those studies we did Dopplers on healthy volunteers under the age of 50 and found that every single one of them had technically a raised ABPI of over 1. So that was very useful information to have to apply to practice in future and dispute the protocol that was held locally, so that we could start compression much quicker. So in terms of drug injecting, the most common drug that's injected in the UK is heroin, but it may be mixed with other things. It's obviously cut with different things, so you don't really know what's being injected. It's illicit, it's unsterile, it's generally very dirty. And the heroin we have in this country needs to be mixed with an acid, such as citric acid or vitamin C, to break it down. And that in itself can cause burning within the veins and damage to the veins. We also have people mixing the heroin or independently injecting cocaine or crack cocaine. And that also, if the vein is missed, numbs the area, which means that the normal reaction of pain doesn't exist, and so people don't know that the damage they're causing. So cocaine injecting is usually pretty dramatically damaging the skin. And also in Lothian in particular, we had a problem recently with people injecting legal highs, which were highly corrosive and caused a lot of damage, as you can see in that picture. But that doesn't explain what's causing the increase in prevalence of leg ulceration that we're seeing clinically, and risk factors aren't clear. And that's what led me to do my PhD study. So my aims were threefold. I wanted to identify the extent of ulceration, know what the size of the problem was in people who inject. I wanted to look at what the risk factors were in that, and that was all very well working out what the problem was, but I really wanted to know what we could also do about it. And I conducted the study in Glasgow, which has got quite a high problematic population of drug users. I used a mixed methods approach, which was one big study followed by a slightly smaller study, and I interviewed 200 current or former injectors who presented at needle exchanges or drug services across the city. And from that, I was able to identify the prevalence of the sample, and also I asked about risk factors, about injecting habits, and about things that we knew would lead to venous disease, such as prolonged standing or leg fracture, DVT, that kind of thing. Following that, I did a second study which built on the results of the first, and I conducted 15 in-depth interviews amongst people who'd injected and had leg ulceration. And I wanted to know if their experiences matched what I learned in the first part of the study, and wanted to know about their perspectives of leg ulceration and also what they thought we could do to prevent it happening. So the first study, the prevalence was extremely high. In 200 current or previous injectors, I found 15% prevalence rate of leg ulceration. And when you compare that to 1% in the general population, you know it's quite dramatic. And 60% had experienced a skin problem, but I was much more interested in the actual ulceration. So what were the risk factors? Controlling for age and length of injecting career. Obviously, as people get older, they're more likely to have disease and they're more likely to have injected for longer and had more problems. So I controlled for that statistically. And the specific risk factors were injecting in the leg. That won't be terribly surprising because trauma to the leg can lead to ulceration. DVT, we know about post-thrombotic ulceration, but most dramatic really was the femoral injecting. And a lot of people are unaware that femoral or groin injecting occurs, assuming that people who inject drugs tend to use their arms. So it is in fact a hidden area, and one that if we're not aware of it, we're not asking questions that are appropriate. Equally, when people go into their femoral vein, it's very close to the femoral artery, so that can be hit as well, which can cause limb or life-threatening problems. And that femoral site can be used repeatedly. Drug injectors tend to like it. Once they find the femoral vein, they can develop a sinus there so that they can access the vein easily. There's no tourniquet involved. It's very easy and quick access. And they can do it for such a long time without any awareness that there might be any other problems occurring. But as they progress, the femoral vein tends to thicken and scar and get pushed deeper into the groin. So bigger needles need to be used, which cause more damage, and they're more likely to get more severe infections. And of course, there's a higher risk of thrombosis because of the back pressure down the leg and the sluggish blood flow. So I then moved on to phase 2. It's obviously a whistle-stop tour through it, but it took me 10 years, so I've got to get it into 10 minutes. So phase 2 was 15 participants, and I wanted to ask them whether they had the similar experiences. And yes, they had injected in their lower leg predominantly, they had injected in their groin, and they had all experienced a DVT. No participant could tell me what had caused their ulceration. And in fact, most of them denied that the ulceration in their leg was anything to do with their injecting career. What they did report was significant pain, embarrassment, and reduced mobility. They said that of all the problems they'd had with drug use, with incarceration, with infections, with hospitalizations, with losing homes, losing families, losing children, the worst thing about their whole life had been their leg ulceration. And these are young people that will have their ulceration for a long time, clearly, if they survive. What was quite surprising to me, though, was in asking them about their leg ulceration, they had absolutely no idea that it was linked in any way to going into their groin, and it was a mystery to them. And it was also a mystery to the health professionals caring for them, Given that they all had ulceration active at the time of interview and were all being treated by health professionals, that none of them had had any discussion about what might actually have caused that. The relationship between the femoral vein and the ulceration down the leg just didn't seem to have been linked at all. So there was clearly quite a big gap in knowledge. So what the participants thought we should do was start educating about injecting at primary school level. And I think everybody will probably have a different opinion about that, and that's not something really that I want to comment on. There's obviously a number of different issues about that, but they felt very strongly that injecting and pictures of leg ulceration should be brought in at the time that they started to think about substance misuse. And many of my sample had started injecting before the age of 16. And had been using drugs before that, and we're now looking at a lot of second-generation drug users who are taught to inject by their family members, by their parents, by their uncles, by their aunts, that sort of thing. So education is really important, but education also for service staff related to the development of venous disease is important, and talking much more openly about injecting and injecting habits in the groin. It's much more common than people know. And certainly within Scotland, many people will start injecting in their groin. They won't even try with their arms. They'll go straight to the groin. That's what they're taught. And it's hidden, clearly. There is harm reduction literature in that picture, which is very good and does mention ulceration, but it doesn't mention anything about venous signs in the leg. So I think there's a lot of work that we can do about educating people before ulceration actually occurs. And of course, there needs to be services where people can drop in as well. So within the team I work in, we're trying to put some of this evidence into practice. This is a draft of something we've been working on, trying to draw attention. People sit for long times in drug services, waiting for their needles, waiting for their methadone. This is the sort of thing that they could sit and read, something that indicates that they have these problems and they are caused by injecting. Interestingly, when we were looking for photographs for the poster, we just asked randomly people coming into the drug service, have you ever injected in your groin? Can we have a look at your legs? And this was very easy photographs to obtain because so many of them had injected in their groin and so many of them had these signs but didn't really understand that they were in any relationship to the injecting habits they'd had. So just a word about treatment. Generally, these ulcers tend to be of pure venous etiology. It's the veins that are damaged more than the arteries. But they do heal very easily, and they also can tolerate quite high compression. The difficulty is getting them to attend and have a flexible enough service that people can come along. We don't have appointment times where I work. They just can drop in. Sometimes they miss the clinic, and that really just results in very sustained compression, potentially a bad smell, but nothing really dramatic tends to happen if the compression stays on for much longer than it should do. Social circumstances are also important. Providing prescriptions for dressings or elastic hosiery isn't necessarily a good idea if you've got a client who lives in a tent or sleeps in a graveyard. They have nowhere to store things, nowhere to wash, so you have to be very aware of social circumstances when you're planning your treatment. And things like recommendations about food banks and free food services are very relevant to this group. So just to summarise, people who inject below the waist are at risk of leg ulceration. And I suppose that's the key message. Be aware when you see substance misusers that they might be injecting in their groin and that might be the cause of the problem. Raising awareness of the damage to the lower limb very early, I think, will eventually help us to reduce the incidence of end-stage venous disease by getting there early and preventing the escalation. Thank you.
Thank you very much. Are there any questions? Yes, one at the back.
Ready? Thank you, Alison. That was really interesting. An interesting population to work with, I imagine. I was wondering, you said when they were coming in you were able to get those photographs because so many of them were injecting in the groin and showing signs. Have you been able to do any preventative work with those that haven't developed ulcers yet?
Not yet. This is this is just a very first draft, and I only finished my PhD last year, so we're taking it forward now. But we're going to evaluate it as we go, so hopefully we'll have some results.
Have you any
Year or
thoughts
two.
on what might work for them in helping them understand what could happen in terms of ulceration and what they might engage in to prevent that happening, if giving up the drugs isn't an option, for instance, for them?
Well, there's different routes that you can use instead of injecting in the groin, and trying to stop people going into the leg completely is what we would aim to do. And sometimes that's about showing them different ways of injecting, different ways of taking their drugs, or actually just saying, look, you've reached an end stage point now, you've got damage, you've got physical signs of that damage. If you continue, you could lose your leg. Because actually describing what an ulcer, the impact of an ulcer, is quite difficult to do. So a lot of talking.
Just one more question down the front for Alison Hopkins. I think Alison will be also available at coffee time if anyone wants got further questions. She'll love it.
Not this Alison, that Alison.
Yeah, that
Alison, that old chestnut about 1.3, I remember talking to you about this many years ago, and we still hear it now. So what would your advice be for those that have very, very rigid guidelines that say 1.3 danger alert for a younger group where it's irrelevant? What would your thoughts be on that?
I was showing them some of the evidence. It's quite small. These were really small studies, but they're there, and reference to them were made in the Scottish Sign Guidelines last time we updated them. So just raising the awareness of that, because otherwise you're stopping treatment completely, and then you've got a much bigger problem.
Yeah.
So it's just about information.
Yeah, lovely, thank you.
Thank you, Alison. That was an excellent client group that you work with.